Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. For this breakout session, let us learn about the latest guidelines regarding superficial venous thrombosis and varicosities with Dr. Gertie May Plameras, a cardiologist and a vascular medicine specialist. She is an active consultant in the University of Santo Tomas Hospital and Philippine Heart Center. This session will be moderated by Dr. Kevin Frehil.
Chronic venous disease is often overlooked by healthcare providers because of the underappreciation of the magnitude of the problem and the incomplete recognition of the manifestations of venous disorders. So varicose veins are the most common manifestation of chronic venous disease. They are the tortuous, dilated, bulging superficial veins measuring more than 4 millimeters, and the estimated prevalence is between 5 and 30% of the adult population. So the female to male predominance of varicose veins is 3:1. So there is a local study done by Doctors Maravilla et al. On the prevalence of chronic venous disease among the adult population using the Southern Tagalog Venous Insufficiency Questionnaire. And it showed that the crude prevalence rate of chronic venous disease is 52.3%, predominantly seen in females, with 38% having the typical venous symptoms. So they concluded from this study that chronic venous disease is relatively common in our country, occurring in 5 out of 10 Filipinos. So aside from varicose veins, other patterns of venous pathology include the reticular veins, which are small, 1 to 3 millimeter in diameter, flat blue-green colored veins, or the spider veins or telangiectasia, measuring less than 1 millimeter, usually purplish to reddish in color. So these are the risk factors found to be associated with chronic venous insufficiency: advancing age, female sex, family history of varicose veins, obesity, pregnancy, previous leg injury, and even prolonged standing and sitting posture at work. So to appreciate the pathophysiology of chronic venous insufficiency, it is useful for us to understand the normal venous anatomy and function. So the veins of the lower extremities are divided into 3 systems. You have the deep veins, superficial veins, and the perforating veins. So the deep venous system is located below the muscular fascia and serves as the collecting veins and the outflow from the extremity. They follow the course of the major arteries and intramuscular veins. The superficial vein system, on the other hand, is located above the muscular fascia and is composed of the great saphenous vein and the small saphenous vein. The perforating veins connect the superficial and the deep venous system. So the main pathology in chronic venous insufficiency is venous hypertension. So in this illustration, the green line represents the normal venous pressure in a healthy limb. So venous pressure is lowest in supine position at 10 millimeters mercury, increasing to 80 to 90 millimeters mercury in standing position. And then the pressure drops to 20 to 30 millimeters mercury when you are walking or during calf exercise. So venous pathology develops when venous pressure is increased and return of blood is impaired through the following mechanism. First, you have valvular incompetence or insufficiency, wherein the incompetent valves allow the retrograde flow of blood, or what we call reflux, which can increase hydrostatic pressure. Second mechanism would be because of venous obstruction due to deep vein thrombosis or cuff muscle dysfunction. So all these 3 mechanisms contribute to venous hypertension. So regardless of the mechanism, venous hypertension leads to the following changes in both the skin and subcutaneous tissue. leading to edema due to increased hydrostatic capillary pressure, inflammation from the macrophages or inflammatory mediators, hemosiderin deposition causing the brownish discoloration of the skin, lipodermatosclerosis or the thickening or fibrosis of the skin and subcutaneous tissue brought about by chronic inflammation, and loss of skin integrity causing ulcer formation. So some of our patients presenting with chronic venous insufficiency, so they have the edema and brownish discoloration of the skin at the gaiters area. So the gaiter area is the area above the malleoli and below the knee where venous pressure is highest. Another patient with lipodermatosclerosis presenting with a thickened skin, warty in appearance, and presence of active and healed ulcers. So again, if you see this kind of presentation at the gaiters area, think of chronic venous disease. So how do we classify chronic venous disease? We have the CEAP classification, which is currently the most commonly used assessment tool for venous disease. So it takes into account the clinical, etiological, anatomical, and pathophysiological components of chronic venous disease. So for the clinical classification, it can be classified from C0 to C6. C0 when you have no visible or palpable signs of venous disease. C1 telangiectasia or reticular veins. C2 you have the varicose veins. C3 edema. C4 the skin pigmentation and lipodermatosclerosis or the skin changes. C5 you have the healed ulcer, and C6 you have the active ulcers. So in the recent 2020 CEAP classification, there is a subclassification for recurrent varicose veins and recurrent ulcers. Also, they added this particular subclass C4C, the corona phlebectatica or ankle flare, which has an increased risk for progression to a venous ulcer. So corona phlebectatica refers to the intradermal veins on the medial and lateral aspects of the ankle and foot. For the etiology, we have three causative factors: congenital, primary, or secondary. So primary venous disease results in superficial venous incompetence brought about by venous hypertension. Congenital factors are those present at birth and are related to disorders of the development of the venous system. For the secondary cause, it was further subcategorized into intravenous or the post-thrombotic intraluminal changes or extravenous due to systemic or intrinsic compression or even muscle pump dysfunction. For the anatomic sites, it can either be superficial, deep, or even perforating vein involvement. For the pathophysiology, it can be due to reflux, obstruction, or even both. So again, these are the CEAP classification: clinical, etiological, anatomical, and pathophysiological classification of chronic venous disease. So for the history, we should take note of the following symptoms: tingling or aching burning pain on the legs, night cramps, swelling, heaviness, leg tiredness, fatigue, restless leg, or even itchy skin. So these symptoms are exacerbated by heat or dependency and relieved by resting, leg elevation, or use of compression therapy. So also pertinent in our medical history are the risk factors for chronic venous insufficiency as follows. Likewise, for premenopausal women with varicose veins, you should also ask for symptoms of chronic pelvic congestion syndrome, wherein they will complain of pelvic pain, heaviness, or dyspareunia. For the physical examination, preferably perform it when your patient is standing so that the varicosities would be more prominent. So inspect for the size, location, distribution of prominent veins, skin changes, and ulceration. You can also palpate for tenderness, palpable vessels, thrill, and even pulses. For patients with vascular malformation, you can auscultate for bruit. So again, examples of patients with chronic venous disease presenting with hyperpigmentation, hemosiderin deposition, at the gator area with another patient with corona phlebistatica or ankle flare. So this patient has lipodermatosclerosis. There is subcutaneous fibrosis that results in significant narrowing of the distal lower limb, causing what we call the reverse champagne bottle sign. So if you see this, think of chronic venous disease. For the diagnostics, duplex ultrasound is the primary diagnostic test of choice for suspected venous disease. So in this particular imaging modality, it allows us to have a comprehensive evaluation of the anatomy. We look for venous obstruction or thrombosis, even the flow direction and reflux. So this slide shows the presence of reflux of the great saphenous vein exhibiting the reverse venous flow that is suggestive of an incompetent valve. Other imaging modalities that can be used are CT or MR venography to image or to look for proximal vein problems like iliac vein obstruction, pelvic congestion syndrome, and even intra-abdominal venous disease. Contrast venography can be used to plan for endovascular treatment like angioplasty or stenting, especially in patients with iliac vein obstruction. So for the management, treatment for chronic venous disease can be either managed conservatively or invasively. So for the conservative management, you have a lifestyle change by losing weight, exercise. Also, you can do compression therapy or give pharmacotherapy. So basically, all our patients are appropriate for conservative measures. The use of more invasive techniques depend on the presence of complications like ulcerations or even persistence of symptoms despite conservative therapy. So compression therapy remains the cornerstone of conservative management. It is effective in managing venous hypertension by improving muscle pump function, resulting to reduction in venous pressure and eventually reduction of edema. So you can either use your compression garments in the form of stockings or elastic bandages, or even intermittent pneumatic compression. So elastic stockings are recommended as an effective modality for symptoms and signs of chronic venous disease with a class 1B recommendation. So when we prescribe compression stockings, you have to take note of its length, compression pressure, and when should you wear it. So for the length, so you have to take note whether it's knee high or thigh high. With regards to the compression pressure, the recommended compression pressure for patients with CEAP class C2 to 3 or those with varicose veins or edema would be 20 to 30 millimeters mercury. And for those with skin changes already or ulceration or under C4 to C6, they need a higher compression pressure at 30 to 40 millimeters mercury. Also, stockings should be worn during waking hours, and it should be removed at night where venous pressure is lowest in the supine position. So likewise, for our stockings to be effective, it should require proper fitting and should be replaced at intervals of 3 to 4 months. On the other hand, compression bandages can be used instead of stockings, especially in patients with venous ulcer because it's easier to apply and also it promotes healing. For the medical treatment of chronic venous disease, we have the venoactive drugs that can decrease capillary permeability, diminish release of inflammatory mediators, or improve venous tone. So examples of these venoactive drugs or the venotonics are your micronized purified flavonoid fraction or your diosmine plus hesperidine, horse chestnut extracts, or coumarins. According to the International Union of Angiology, the following medications together with compression therapy can improve healing of venous ulcers. So these medications are your MPFF, your diosmine plus hesperidine, pentoxifylline, and sulodexide. In this Suavis study, they used sulodexide, 1 ampule for 20 days, followed by 2 capsules twice a day for 70 days. And it resulted in complete ulcer healing in 2 months' time. So sulodexide is an endothelial protecting agent which has an effect on the blood flow and acts on the vessel wall, restoring the proper function of the endothelium. So with its effect on both the micro and macro circulation, sulodexide is one of the drugs that can be used in patients with chronic venous insufficiency to relieve the symptoms and promote healing of venous ulcers. So I just want to highlight that routine use of systemic antibiotics to promote healing of venous ulcers, it's not recommended. We only give antibiotics if there are signs of clinical infection like your cellulitis or infected ulcerations, and not for bacterial colonization. So we now go to the more invasive therapy in the management of chronic venous disease. First, you have sclerotherapy. So sclerotherapy involves injection of the varicose veins, reticular veins, and even the telangiectasia with liquid or foam chemical agents to damage the endothelium and later on closes the vein. Transcutaneous laser has been used for the treatment of telangiectasia and reticular veins. So the mechanism behind this treatment is to cause endothelial injury of the vein by heating the hemoglobin and eventually obliterating the lumen. Endovenous thermal ablation using laser or radiofrequency ablation in the treatment of saphenous vein incompetence have become very popular as a minimally invasive alternative to classical surgery. So this procedure is performed percutaneously with ultrasound guidance, and a laser fiber or radiofrequency catheter is inserted and positioned near the saphenofemoral junction, and a tumescent liquid is injected around the saphenous vein. So while withdrawing the catheter or the fiber, energy is emitted intraluminally to cause irreversible thermal destruction of the endothelium of the vein, which eventually closes the vein. So endovenous thermal ablation is the treatment of choice for patients with great saphenous vein reflux having signs and symptoms of chronic venous disease. So some patients who had endovenous thermal ablation, you can see that after treatment, there is disappearance of the varicose veins. Vein stripping, on the other hand, is performed selectively nowadays in the advent of the endovenous thermal ablation. So who can benefit from this particular surgery? Those with large portosaphenous veins, very superficial grade saphenous veins, those with partially recanalized veins due to thrombophlebitis that cannot be cannulated using the ablation probe. So for the last part of my lecture, I'll be discussing superficial vein thrombosis. So goals of treatment would be to alleviate the local symptoms of pain and tenderness, prevent thromboembolic complications like deep vein thrombosis or even pulmonary embolism, and prevent recurrence. So in patients suspected to have superficial vein thrombosis, venous duplex scan is recommended to establish the diagnosis. If you have a confirmed superficial vein thrombosis and deep vein thrombosis, so treat as DVT, so give your therapeutic anticoagulation. If you have a confirmed isolated superficial vein thrombosis and it is near the saphenofemoral junction, meaning it is less than 3 centimeters from the saphenofemoral junction, it means that it has a higher risk of extending into the deep venous system, and so you have to treat it just like how you treat vein thrombosis. So give the therapeutic anticoagulation. If your patient, on the other hand, has an isolated superficial vein thrombosis, but the location is quite far from the saphenofemoral junction, more than 3 centimeters, but the length of the thrombus is more than 5 centimeters, you may give the following treatment. So either low molecular weight heparin, fondaparinux, or rivaroxaban for 45 days. So rivaroxaban is off-label for this indication. But in the SURPRISE trial, which compared fondaparinux and rivaroxaban in patients with superficial vein thrombosis, results showed that rivaroxaban was non-inferior to fondaparinux in preventing thromboembolic complications with comparable safety. Lastly, for patients with thrombus more than 3 centimeters from the junction and the length of the thrombus is less than 5 centimeters, you may opt to be conservative and just give your NSAIDs. However, if there will be worsening of symptoms or if there will be risk for VTE, then anticoagulation can be started. So that is my last slide. Thank you for your kind attention.
DVT is a common problem during this pandemic. Let us learn about the latest guidelines and updates on thromboprophylaxis during these times with Dr. Ralph Carandang, a vascular medicine specialist currently practicing at the Philippine Heart Center. This session will be moderated by Dr. Kevin Frahil.
Good morning, everyone. I'll be discussing about a deep venous thrombosis and thromboprophylaxis in the time of COVID-19. As a brief introduction, deep venous thrombosis, or DVT, is defined as obstruction of a deep vein by a thrombus. It usually originates in the pelvic or deep leg veins, and some thrombi may be dislodged from the vein and embolized to the lungs, producing pulmonary embolism. That is why PE and DVT is collectively known as venous thromboembolism, or VTE. According to the American Heart Association, in 2014 alone, there were 676,000 DVT cases recorded. In the local setting, we did a retrospective study from 2013 to 2015, and we recorded 112 cases of VTE, combined DVT and PE. I think this is less than the actual cases because of the VTE being underdiagnosed. For the pathophysiology, Virchow's triad of stasis, hypercoagulability, and endothelial injury has served as the foundation of our understanding of VTE pathophysiology. However, recent concepts prioritize inflammation, which is usually brought about by infection, as possibly one of the important root causes of VTE, especially now in the time of the pandemic. The incidence of DVT is dependent on the prevalence of associated risk factors. Here is a list of known important independent risk factors with their corresponding relative risk. They are subdivided into established risk factor and emerging risk factor. For the established risk factor, the most important ones are those caused by hospitalization. Also, namely major surgery with a relative risk of 20, hospitalization for acute medical illness, trauma or fracture, active cancer. Another important established risk factor is hereditary thrombophilia, which can reach as high as 12 for its relative risk. For the emerging risk factors, the important one is the elevated D dimer, which is widely used, usually included in the predictive scoring for VTE. Now, for the classification, we can classify VTE into provoked and unprovoked. Now, for provoked VTE, it is usually caused by an intervention or an event that leads to development of VTE. It can further be subdivided into a transient risk factor or a persistent risk factor. For the transient risk factors, this includes surgery with general anesthesia, confinement to bed, cast immobilization, cesarean section, and the likes. For the persistent risk factors, so as the name implies, the risk is usually longer, expected to be longer. like for example, active cancer, especially those with ongoing treatment or those with metastatic or progressive disease, as well as neurologic disease with leg paresis. For the second classification, we call it unprovoked VTE, so not in either of the above classification. But usually we call it idiopathic, but now we term it as unprovoked. Another way of classifying DVT is through its location. No, so here is an illustration of the deep leg veins. So starting from the external iliac vein down to the common femoral vein, which branches into deep femoral vein and superficial femoral vein, then popliteal vein, then into the trifurcation vein. Now, so if you have DVT involving the popliteal vein and above, so you're dealing with a proximal DVT, which comprises around 70 to 80% of the cases. And the remaining 20 to 30% is termed as a distal DVT, so those involving the trifurcation veins. So these two classification is very important, especially in the management of DVT, which I'll be discussing later. Now, for the clinical manifestation, the most common, of course, is swelling of the extremity. Usually, this is the presenting symptom of the patient. They may also complain of extremity discomfort, described as cramping or pulling sensation, some with unexplained fever. Now, the swelling may also affect the upper extremities, especially those with indwelling catheter. For the physical examination, you can see swelling, tenderness, warmth, erythema. It is most often unilateral, but can present as bilateral as well, especially if it involves the more proximal portion of the vein, like the iliacs, or if it involves the upper extremities. Now, for the DVT and diagnostic management algorithm, I listed this algorithm from the joint consensus document of the European Society of Cardiology and Managing DVT, published in the European Heart Journal last 2018. So the algorithm begins. The first step is the pretest probability assessment. So there are various predictive scoring for VTE, but the widely used is the Wells scoring. So the Wells scoring can be used in an outpatient or inpatient basis. It consists of clinical variables, as you can see here, with their corresponding points. Now, you can classify DVT into 3-level Wells score or 2-level Wells score, but the ESC, the European Society of Cardiology, prefers the 2-level Wells scoring. Now, if you have a Wells score of less than 1 or less than 1, then DVT is unlikely. If the scoring or the points is 2 or more, then DVT is likely. So going back to the algorithm, so if you have 1 or less than 1 score in the Wells score, then DVT is unlikely. So the next step, they recommend to request for a D-dimer. Now, D-dimer is available in most hospitals in our country. It's a non-specific marker of endogenous fibrinolysis. Using ELISA, it can yield up to 96.4% sensitivity, but with a very low specificity. It has a high negative predictive value, as high as 99.6%. That is why a negative D-dimer, we can already rule out or exclude the diagnosis of DVT. It is important also to note alternative causes or elevated D-dimer that can give you false positives. So this include cancer, pregnancy, post-operative state, infection, liver and renal disease, trauma, aortic dissection, MI, stroke, and DIC. So usually these are diseases with inflammatory processes. Now, if the D-dimer is positive, then you'll proceed to the right side of the algorithm. Now, or if the Wells score gives you a score of 2 or more, then DVT is likely. Therefore, if there is high likelihood of DVT, you should no longer request for a D-dimer. and proceed with a complete venous ultrasound or the compression ultrasound. No, so venous ultrasound, compression ultrasound, DVT screening, venous duplex scan, so they're all the same. No, this is the first line DVT imaging modality. No, it has the DVT diagnostic criteria are the following: cross-sectional vein incompressibility, direct thrombus imaging with vein enlargement, abnormal spectral and polar Doppler flow. No, so these are the three diagnostic criteria. So here is a video. This is a normal vein. This is the common femoral vein. No, so when you apply pressure using the ultrasound probe, the vein should collapse completely. It should be compressed completely. So the vein wall should kiss each other. So these are both arteries, so they are not really compressible, only the veins. If you're dealing with DVT, as you can see here in the lower video, if you apply pressure, there is incompressibility of the vein. So here, so you can see, you cannot compress the vein. There is the presence of intraluminal density consistent with a thrombus. And if you apply color in this video, flow cannot be appreciated. And there is also an abnormal spectral flow. Venous ultrasound has a very high sensitivity and specificity. Other imaging modality includes CT or MR venography. So in rare instances, the CT or MR venography is required, especially those involving the proximal veins, the iliac veins or the subclavian veins for the upper extremity, because you cannot compress those venous segments because of the presence of bony prominences. So there, if the complete venous ultrasound is positive for proximal DVT, so remember, proximal involves the popliteal vein up to the external iliac vein, then you should already start treatment, at least 3 months of anticoagulation. The ESC recommends the use of direct oral anticoagulants or DOACs in non-cancer patients if there are no contraindication. So this is also listed in the ESC guideline, the management of DVT. It is anticoagulation, still the foundation of therapy for DVT. It usually consists of 3 phases: initial treatment, long-term treatment, and extended treatment. Now, for the initial treatment, it can vary to 5 to 21 days, depending on the regimen that you will be using. Like, for example, all apixaban, the Decatran, the Varoxabans are available in the country except for edoxaban. If you're using apixaban, the recommended dose is 10 milligram twice a day for 7 days. That's the initial treatment. And then followed by 5 milligrams of apixaban twice a day for 3 to 6 months. If you, after risk assessment, or if you plan to extend the treatment, so I'll be discussing later on when will be the timing, or what are the indications for extended treatment, then you can decrease the apixaban to 2.5 milligrams twice a day beyond 6 months or during the extended treatment. If you'll be using the Decatran, 150 milligram twice a day is the regimen. But this should be preceded by the use of low molecular weight heparin for 5 to 10 days. So low molecular weight heparin first, then followed by the Decatran. For rivaroxaban, it's 15 milligram twice a day for 21 days. So it's a little longer compared to the other 2 DOACs. And for the long-term treatment, it's 20 milligrams once a day. And then if you plan to extend the anticoagulation for those high-risk recurrences, you can decrease it to rivaroxaban 10 milligrams once a day, or maintain it at 20 milligrams once a day. Vitamin K antagonist, or VKA, or warfarin can still be used, especially in our country. Not all can afford DOAC, so it's still up to use warfarin. but you need to monitor the INR. And also, similar to the Bicatran, it should be preceded by low molecular weight heparin for 5 to 10 days, then followed by VKA or until the goal INR is reached. You know, the INR, the goal INR is 2 to 3. Okay. For the parenteral anticoagulation, now in patients with severe renal failure, for those with creatinine clearance of 30 millimeter per minute, or those with unstable renal function, unfractionated heparin is still preferable. No? Uh, However, the main disadvantage of unfractionated heparin is its inter-individual dose variability. No, it also requires laboratory monitoring, the EPTT, and then dose adjustment thereafter. Additionally, unfractionated heparin is associated with the high risk of heparin-induced thrombocytopenia. For these reasons, low molecular weight heparin like enoxaparin, fondaparinol, or tinsaparin is the parenteral treatment of choice. Low molecular weight heparins are at least as effective as unfractionated heparin and are probably safer. No? Now, how about isolated distal DVT? So when do we treat isolated distal DVT? No, so you can classify isolated distal DVT into high risk recurrence and low risk recurrence. For high risk recurrence, you should start treatment for 3 months anticoagulation. So just like proximal DVT. No, however, for low risk isolated distal DVT, the physician has the choice to do treatment or surveillance. No, so if you plan to treat, then you should give anticoagulation for 4 to 6 weeks, no, full or a lower dose, or you can opt to do venous ultrasound surveillance. No, so after a week, you request for another venous ultrasound. If it's negative, then you can you can opt not to give anticoagulation. No, or if the DVT progresses, no, now it involves the popliteal or the upper venous segments, then you start standard anticoagulation. Now, so these are the conditions, not the high risk conditions for isolated distal DVT that can help you decide whether to give anticoagulation for this group of patients. No? So the high risk conditions include previous VTE events, male, those elderly patients with cancer, unprovoked isolated distal DVT, and the likes. For the low risk condition, so the physician has the option to treat or to do surveillance if the isolated distal DVT is secondary to surgery or transient risk factors, and the following. Now, for the recurrence, after the standard treatment, I mean the first 3 to 6 months, including the initial treatment phase, you should always reassess your patient. No? If you have a high risk of recurrence, then you can do extended anticoagulation therapy. If not, no, if the venous thrombosis resolved, then and the risk factor already resolved also, then you can stop anticoagulation. For you to help you decide, these are the clinical prediction rules assessing risk of recurrent VTE. No, so they are a little tedious, especially Vienna, because you're requesting for D-dimer. No, but no, you can use any of these 3 prediction scores. So if you have a score of more than 2, no, there is a high recurrence of VTE, then probably you should extend the treatment for more than 6 months, but a lower dose than the standard regimen. Now, we all know that VTE, especially PE, is the most preventable cause of in-hospital death. No, so thromboprophylaxis is very important, no, especially for those high-risk patients. So this is another risk scoring to help us decide whether to give prophylaxis anticoagulation. So this is applicable for hospitalized medical patients. These are the risk factor and their corresponding points. If the Padua score is more than or equal to 4, then there is a high risk of venous thromboembolism, then you should start anticoagulation. Now, it's different for surgical patients. So this is a more busy, more tedious prediction score, the Caprini risk assessment model. No, so here the variables include age, the type of surgery, the duration of surgery, the duration of confinement, no, laboratories such as prothrombin, risk factor, thrombophilia, no, if you reach the score of 5 or more, then there is high risk or high likelihood of development of VTE. Then you should start prophylactic anticoagulation. So this is the regimen for VTE prevention for hospitalization with medical illness. You can use unfractionated heparin. No, heparin can be given as sub-Q also, not only intravenous. No, so you can also use low molecular weight heparin and DOAC, especially for major orthopedic surgery. Now, for those where anticoagulation is contraindicated or high bleeding risk, you can use non-pharmacologic VTE prevention, such as intermittent pneumatic compression or graduated compression. Okay, so let's proceed with the second part of my lecture, which is thromboprophylaxis in the time of the pandemic. So this is a table showing you the prevalence and incidence of VTE in critically ill patients with COVID-19. These are several studies published last year, which shows the incidence of VTE as high as 35% in one study by Keok et al. That's 65 patients over 65 patients out of 184 admitted patients who developed PE with DVT. Now, another study by Lithios et al. Recorded 54% of isolated leg DVT. No? So that's higher, although the sample size is smaller compared to the previous study. No? So the postulated mechanism of coagulopathy and pathogenesis of thrombosis in COVID-19 is shown here in this illustration. The SARS-CoV-2 virus activates an inflammatory response, leading to a release of inflammatory mediators. So this is coupled by different risk factors of COVID-19 patients, the acute illness, the bedridden state, liver injury, in severe cases. The inflammatory response and the endothelial dysfunction is marked with lymphopenia, with increase in inflammatory cytokines and interleukin-6 and CRP. This renders a procoagulant effect, hemostatic abnormalities, which leads to development of pulmonary microthrombi, intravascular coagulopathy, myocardial injury, increase in cardiac biomarkers. The laboratory will show you increase in the levels of D-dimers, FDPs, prothrombin time, increase or decrease in the platelet levels. For the clinical outcomes, you can have VTE, whether it be PE or DVT. Some may have myocardial infarction or DIC. That is why several societies published guidelines and they recommend starting prophylactic anticoagulation in COVID-19 patients. So I reviewed two of these guidelines, one published by the International Society on Thrombosis and Hemostasis last May 2020. Another is the CHEST guideline published, I think this is September 2020. They have similarities and also some key differences. The ISTH guideline recommend routine thromboprophylaxis with standard dose unfractionated heparin or low molecular weight heparin, but the preferred agent is low molecular weight heparin. They recommend that the dosage should be modified based on extremes of body weight or severe thrombocytopenia or deteriorating renal function. As for the chest guideline, similar to ISTH guideline, they recommend low molecular weight heparin or fondaparinux over unfractionated heparin. They do not recommend the use of direct oral anticoagulant or DOACs because of drug-to-drug interaction with novel treatment for COVID-19 patients, no, such as the antivirals that we're currently using. For VT prophylaxis in ICU and critically ill COVID-19 patients, both of them recommend routine thromboprophylaxis with unfractionated heparin or low molecular weight heparin with preference to low molecular weight heparin. Now, the ISTH guideline also mentioned intermediate dose low molecular weight heparin to be considered in high-risk patients. They also mention an increase of 50% in the dosage of thromboprophylaxis in those with patients with obesity. However, the chest guideline, they stick to the current standard dose anticoagulation thromboprophylaxis over intermediate dosage. So when you say intermediate pala, it's the BID dosing or twice daily dosing of the anticoagulation. For them, there is more study is needed for them to recommend the intermediate dosing or increased weight-based dosing of weight-based dosing of anticoagulation. Now, for the duration of thromboprophylaxis, the ISTH guideline recommends either the use of low molecular weight heparin or DOAC, such as rivaroxaban, for extended duration thromboprophylaxis, especially those that meet the high VT risk criteria. The duration of post-discharge thromboprophylaxis can be approximately 14 days up to 30 days. But for the chest guideline, they recommend inpatient thromboprophylaxis only over inpatient. So the chest guideline is a little conservative, no, compared to the ICTH guideline. No, so but there's no right or wrong way of doing it. No, as long as there is risk assessment. No, you assess the bleeding risk of the patient, whether the patient has high recurrence rate, then you'll be able to decide what is the proper anticoagulation to be given. Actually, we have a local guideline for anticoagulation. No, our society, the Philippine Society of Vascular Medicine, published this algorithm for COVID-19 patients. No, so whether it be a COVID positive, a suspect, or probable, if they fulfill one of these 4 red boxes, no, then the society recommend to start prophylactic anticoagulation. So let's look at them one by one. First, with the ICTH criteria, they use D dimer, no, as parameter. If it's more than 2 microgram per ml, with prolonged pro time and increase in the platelet level, specifically less than 100, then it's recommended to start prophylactic anticoagulation. You can also use PADWA score, just like for those patients for non-COVID patients. If the PADWA score is more than 4, no, equivalent to a very high risk of developing VTE, then prophylactic anticoagulation is recommended. No, so these 2 boxes is somewhat tedious. No, so for the sepsis-induced coagulopathy score, you need 3 parameters: PT-INR and platelet count, as well as SOFA scoring. No, if the PT-INR is within this range, 1.2 to 1.4, you have a score of 1. If it's more than 1.4, then score of 2. No, so platelet count, as you see in the table. No, and for the SOFA score, we'll use this SOFA scoring. No, with the variables including respiratory, cardiovascular, liver, renal, and coagulation parameters such as platelet, and also GCS score is also included in SOFA scoring. Now, so if you have a total score of 4, more than or equal to 4, then sepsis-induced coagulopathy is suspected, and you should start prophylactic anticoagulation. So this is the recommended dose. Similar with the ISTH and the chest guideline, the society prefers enoxaparin and unfractionated heparin. For enoxaparin, it is weight-based dosing, no, is utilized, as well as adjustment for creatinine clearance. So it's 40, 60, 80 milligram per sub QOD respectively, based on the body weight. No, for those with creatinine clearance of less than 15 ml per minute, no, unfractionated heparin is recommended, 5,000 units sub Q, divided either into 3 or 2 doses. For those patients with contraindication to anticoagulation, the society recommend the use of intermittent pneumatic compression or graduated compression stockings. No? And during the admission, you should always reassess your patient if there is likelihood of the development of PE, DVT, then like what I showed you before, you should apply the algorithm for VTE, and if you suspect DVT and PE turns out to be positive, then you increase the dose of the anticoagulation to the therapeutic dosing. So I think this is my last slide. Thank you for listening.
You may now proceed to our industry-sponsored symposia. Please go to www.tiktok2021.com and click on the room you would like to join.